This lecture will go over treatment for sinus bradycardia, specifically pacing. We talked about with sinus bradycardia, the treatment depends on what's causing the problem. So if we can treat the underlying cause, then that's going to fix it. For instance, if your client with a tracheostomy becomes diaphoretic and nauseous with a heart rate of 39 beats per minute while suctioning, the treatment would be to stop suctioning, right? You just eliminate whatever it is that's causing that bradycardia. If the underlying cause cannot be determined, we talked about using atropine, IV fluids, and oxygen. Or again, if it's an overdose, treating whatever that specific overdose is. If the heart rate does not increase sufficiently, the patient may have transcutaneous or transvenous pacing. If the treatment of the underlying cause does not restore normal sinus rhythm, then the patient may require permanent pacemaker implantation. So temporary pacing, what is that? It is a non-surgical intervention that provides a timed electrical stimulus to the heart when either the impulse initiation or the conduction system of the heart is defective. So most of you, I'm sure, are familiar with an implanted pacemaker. Hopefully you've seen one where they have a little bulge under their clavicle, under the skin, where the implanted pacemaker or pacer defibrillator is located. In this case, so there's been no surgery to put a pacemaker in, but we're saying the patient needs help with pacing of the heart. So the patient may have a temporary pacing device used until either the problem can be addressed or they can get in and get the pacemaker implanted. Temporary pacing is used for patients with symptomatic bradydysrhythmias who do not respond to atropine, or for patients with asystole. So the first one we're going to talk about is transcutaneous pacing. Is accomplished through the application of two large external electrodes, and you can see that in the top figure on your slide there. Transcutaneous pacing is used as an emergency measure to provide demand ventricular pacing in a profoundly bradycardic or asystolic patient until invasive pacing can be used, or the patient's heart rate returns to normal. This method of pacing is painful and may require the administration of pain or sedative medications. Transcutaneous pacing is used only as a temporary measure to maintain heart rate and perfusion until a more permanent method of pacing is used. A temporary transvenous system can be inserted in an emergency as a bridge until a permanent pacemaker can be inserted. It consists of an external battery-operated pulse generator and pacing electrodes or lead wire. The wire attaches to the generator on one end and is threaded into the right ventricle via the subclavian or femoral vein. The two major modes of pacing are synchronous or demand pacing and asynchronous or fixed rate pacing. Temporary pacing is usually done in the synchronous or demand pacing mode. The pacemaker's sensitivity is set to sense the patient's own heartbeats. When the patient's heart rate is above the set rate of pulse generator, the pacemaker does not fire. When the heart rate is less than the generator setting, the pacemaker provides electrical impulses. When a pacing stimulus is delivered to the heart, a spike or pacemaker artifact is seen on the monitor or ECG strip. The spike should be followed by evidence of depolarization such as P wave or QRS complex. The pattern is referred to as a capture. So on the ECG strip, you'll see a marking indicating that the pacemaker has fired. And then after that, if the pacer has captured, you would then see either the P or QRS following immediately after the pacer spike. If it does not capture, then you'd see the mark indicating the pacer has sent out an impulse, but nothing behind it, and that would be considered or termed that it has not captured. In terms of a permanent pacemaker insertion is performed to treat conduction disorders that are not temporary, including complete heart block. These pacemakers usually are powered by a lithium battery and have an average lifespan of 10 years. Some nuclear-powered pacemakers can have a lifespan of 20 years or longer, and other pacemakers can be recharged externally. A permanent pacemaker is usually implanted surgically in the subcutaneous pocket at the shoulder and the right or left subclavicular area, which may create a visible bulge. After the procedure, monitor the ECG rhythm to check that the pacemaker is working correctly. Assess the implantation site for bleeding, swelling, redness, tenderness, and infection. The dressing over the site should remain clean and dry. The patient should be afebrile and have stable vital signs. The healthcare provider prescribes initial activity restrictions, which are then gradually increased. Complications of permanent pacemakers are similar to those of temporary invasive pacing and include development of pericardial effusion, pericardial tamponade, and diaphragmatic pacing. In diaphragmatic pacing, the patient may report pain at the level of the diaphragm. Observe for muscle contractions over the diaphragm that are synchronous with the heart rate. The pulse generator is interrogated using an electronic device to determine the pacemaker settings and battery life. That would be used for reprogramming if reprogramming were needed. In terms of nursing considerations, we want to give written and verbal information to patients who have a permanent pacemaker about the type and settings of the pacemaker. Teach the patient to report any pulse rate lower than that set for the pacemaker because it may indicate that the pacemaker is not working properly. Review proper care of the pacemaker insertion site and the importance of reporting any fever, redness, swelling, or drainage at the insertion site. If the surgical incision is near either shoulder, advise the patient to avoid lifting the arm over the head or lifting more than 10 pounds for the next 4 weeks because this could dislodge the pacemaker wire. Encourage the patient that usual arm movement is encouraged to prevent shoulder stiffness. Teach patients to keep handheld cellular phones at least 6 inches away from the generator, with the handset on the ear opposite the side of the generator. Avoid sources of strong electromagnetic fields, such as magnets and telecommunications transmitters. And carry a pacemaker identification card provided by the manufacturer, and wear a medical alert bracelet at all times. So if you're working in the ED or on the floor and you have a patient with a pacemaker, you'd want to ask them for their pacemaker card and make a copy of that for their file. Chart 34-3 is a chart about patient and family education in regards to permanent pacemakers, and I want you to go ahead and review that on your own.